will be presented by Professor Fiona Rowe, Professor of Orthoptics and Clinical Lead at the Institute of Population Health, University of Liverpool, UK, who will present the ESO Guideline on visual impairment and stroke. Thank you very much.
Thank you very much. So the Vision Guideline, first of all, these are my disclosures, and the disclosures for the full guideline group are outlined in the guideline publication, which has gone live today. So the Vision Guideline Working Group has 10 members, and these 10 members are from 7 countries and 5 different professional groups. Our remit is as stated here, and this was to provide evidence-based recommendations for clinicians who care for stroke survivors who might develop visual impairment as a consequence to their stroke. This is the final list of 13 questions, PICOs, agreed after discussion, voting, and peer review. The first 7 relate to vision screening of stroke survivors, the timing of this, and detection of visual impairment. And the last 6 questions address the management of different categories of visual impairment. We provide recommendations for 7 of these PICOs where there was sufficient evidence, and expert consensus statements are provided for 6. So PICO 1 asked about routine use of vision screening versus no vision screening, and whether this would improve the detection rate of any form of visual impairment. Now, for this PICO and for all other PICOs, we're only including outcome measures that were independently reviewed and ranked as critically important. So for this particular question, we were focusing on sensitivity, specificity, and detection rate. And we found 2 studies that compared screening at pre-hospital stage by paramedics, and then 6 studies that looked at vision screening at acute stroke care phases. And at acute care, average sensitivity and specificity were high at above 80%. Across 14 studies, we were able to calculate an overall mean detection rate of visual impairment at 65%. Now, PICO 2 went on to look at the timing of vision screening, again looking at any vision screening at early stage within 1 week of onset versus later screening. The outcome measures here were length of stay and time to vision screening. We found 2 studies that reported on length of stay, and there was an average higher duration for patients with visual impairment than those that had normal visual function. But it was noted by the team that visual impairment cannot be considered causal of that length of stay, because that is a multifactorial issue. We found 3 studies that reported on timing of vision screening, and what was found is that early vision screening within 1 week of onset is both feasible and acceptable. And those with visual impairment had worse reported outcomes for both activities of daily living and quality of life. Now, question 3 to 6 had the same shared literature search, and that's because of shared underpinning systematic reviews. So the question for all of these is the same, but focusing now differently for the types of visual impairment and comparing their identification by vision screening or specialist assessment versus a routine stroke screen. So we were looking for these 4 PICOs at sensitivity, specificity, and detection rate again. And within this table, you have the question on the left-hand side. In the middle, you have sensitivity and specificity results. And to the right of the table, you've got the detection rates. So for visual fields, which was mainly hemianopia, the low sensitivity was 5%, and that was for paramedic detection at pre-hospital. But if you look to where most of the screening was done on acute stroke units, then sensitivity and specificity are quite good at 82–83%. Central vision mainly looked at blurred visual acuity or symptoms of blurred vision, and again, sensitivity and specificity values were very good. For eye movement disorders, sensitivity and specificity dropped a little bit. They're a little bit harder to pick up on. And for visual perceptual problems, and this was reporting symptoms of depth issues or dark vision, then sensitivity and specificity ranged from 60 to 86% sensitivity, 86 to 91% specificity. And, looking at detection rates, what you will find here is that there's a variation across the different types of visual impairment, and largely this related to the type of study as to whether these were epidemiology studies or just looking specifically at the type of visual impairment. Moving to visual neglect, we had 4 studies of direct relevance here and a further 5 of related relevance. But across all 9 studies, sensitivity ranged from 60 to 95% and specificity from 32 to 94%. And 13 studies reported an overall mean detection rate of visual neglect at 40%. This is the summarized table of key recommendations and consensus agreements from the Vision Guideline. And the guidance is towards early vision screening for all stroke survivors within 1 week of stroke onset. And this is for all stroke survivors, not just those that self-report visual symptoms, with the purpose that none should be missed. In terms of some diagnostic considerations, in terms of patient preferences, we know that patients are largely willing to undergo early vision screening, whether that's screening or specialist visual assessments, because this is not time-consuming and there's limited risk. In fact, there's probably a higher likelihood of undesirable effects without vision screening, for example, delayed diagnosis or a missed diagnosis, and that would significantly impact on rehabilitation. There are few indications to wait to do vision screening because there are significant numbers of patients that do not report visual symptoms. And there are also limited predictive factors as to who will or will not recover from having a visual impairment. In fact, it's the minority that would have full recovery of visual impairment. So it's an inequality to make all wait and potential detriment to general rehabilitation. With regard to choice of or type of vision screening, there is a time trade-off. Very rapid checks are good for pre-hospital and an emergency room settings, but they lack precision for detecting visual impairment. A validated vision screening tool in the acute stroke unit takes a little bit longer, but provides more accuracy. And in terms of choice of vision screening or specialist assessment, well, we would always say that specialist assessments anywhere would be ideal, but in terms of practicalities across different countries and different services, then usually there's an issue there in terms of resource and staff access. So we promote the use of validated vision screening tools as a basic level. Now, moving on to the management questions, we first looked at whether interventions for homonymous visual field loss compared to no treatment at all might improve activities of daily living or quality of life. And there were 9 directly relevant trials for this question, with critical outcomes including a change in visual field, activities of daily living and quality of life, driving, reading, and a risk of falls. So for this, there were mainly compensatory managements offered, and these were visual scanning training, which aims to improve the detection accuracy to the blind side. Substitutive options were mainly monocular prisms, and those aim to deviate objects from the blind side across to the seeing side of vision. Restitution options typically look at repeated computerized stimulation of the blind hemifield. And what we found across these studies is that there were high adverse events for using prisms, and there were variable outcomes for restitutive options with clinically insignificant changes for visual field sensitivity. And it was only compensatory visual scanning or search training that showed some consistency for improvement, and that was mainly shown in quality of life measures. We then asked whether interventions for ocular stroke, so central retinal artery occlusion, compared to no treatment would improve ADL and quality of life. And here we had 5 directly relevant trials for the question. 5 related to intravenous thrombolysis, and there was 1 trial on hyperbaric oxygen treatment. 4 studies reported a change in visual acuity, and 2 reported a change in functional activities. There were no reports of change for quality of life. And for IVT, the main effect was shown within 4.5 hours. But adverse events also apply to IVT for central retinal artery occlusion, with rates reported at 1 to 11%. For treatment of central visual impairment, which is different to central retinal artery occlusion, so here we're looking at blurred central vision, there were 3 indirectly related studies. The red lines on this table underline where there's been a change. So for 1 study, there was provision of updated or new glasses for stroke survivors, and this improved vision for half that were provided with these glasses. There were 2 studies that reported spontaneous improvement of visual acuity, and this was for half of the study participants over a period of 1 to 26 weeks. Full recovery was noted for a third of those stroke survivors. And these 2 studies also acknowledged the coexistence of pre-existent low vision, but were able to extract out the new onset low vision and report the 2 separately in these studies. There were 2 directly relevant trials reporting management for eye movement disorders. And both of these studies used compensatory interventions. A change in eye movement was significant for the intervention group, but not for the sham or control groups. And change in activities of daily living and quality of life were also significant for the intervention group, with a significant difference between groups. For visual neglect, we looked to see whether interventions compared to no treatment would again improve ADL and quality of life. And here we had the largest number of studies, so there were 44 directly relevant trials and studies to work through. Some interventions, such as brain stimulation, showed improvement of activity of daily living, but also we noted that control groups showed improvement with no significant difference between the groups. There were other trials that showed improvement in visual neglect measures, but not in activities of daily living. We noted that eye patching showed no significant effect at all. In fact, the only interventions that we did find effect were prism adaptation and certain types of visual scanning training, and showing promise in improving ADL and quality of life here. And the last category of visual perception disorders, which are separate to visual neglect, there were 4 directly relevant trials for this PICO. 2 of these studies included compensatory interventions and 2 addressed brain stimulation interventions. All of these studies reported changes in visual perception and activities of daily life. Only 1 reported on quality of life. And the evidence suggests a limited application of these interventions for acute stroke care, and that's most likely because of lack of practicality in acute settings. These may be better suited as a later management for persistent visual perceptual disorders. And in addition, some trials showed improvement for both intervention and control groups, and that effect needs to be unpicked. So for treatment, this table summarizes the key recommendations and consensus statements from the Vision Guideline. The guidance is towards targeted and timely treatment appropriate to the type of visual impairment that is present, so separating out visual field loss, ocular stroke, eye movement disorders, neglect, and visual perception. In terms of areas for further research, we need to encourage more across the areas of diagnosis and management. We need to implement standardized vision screening, and in doing so, we need to evaluate the impact of doing so. We need to look at interventions. We have to consider if there are core outcome sets and measurements that need to be used, particularly in relation to the change in visual function, as well as activities of daily living and quality of life. For visual fields, we need more information about scanning training, but also about restitutive training options. So can that show improvement in discrimination awareness? So what we know as blind sight. We're awaiting outcomes of the central retinal artery occlusion trials. There will be more on that tomorrow, but we need to know how best to implement pathways for that to facilitate the urgent referrals that are needed. And for central visual impairment, we need to scope the impacts of that more widely. So in conclusion, post-stroke visual impairment is very common. There's a prevalence of up to 75%. There is an impact to activities of daily living and quality life. For example, people returning to driving, returning to work, having independence. If there is no standardized care, then that causes a health inequality for these stroke survivors, and some get no eye care at all. And we cannot rely on patients self-reporting their visual symptoms. 40 to 60% are shown in studies to not report their visual symptoms, so they are missed. And we need to look at the knowledge, skills, and awareness, not only amongst the stroke teams, but also amongst the ophthalmology teams. Overall, we recommend a very close collaboration between the stroke and eye care teams so that we can target management of visual impairment, and clinicians should provide appropriate information, resource materials, and vision aids to their stroke survivors. And I would sincerely like to thank my colleagues in the Vision Guideline Working Group and my co-chair, Anna Hegamud from Oslo in Norway. Thank you very much.
Thank you for a very timely presentation with clear messages and for also keeping the time. We have time for a couple of questions. The floor is open. I strongly believe that we need more clear, more prospective observational and randomized data with regard to the effect of thrombolysis on central retinal artery occlusion. And perhaps if there are some positive trials, we may need to have an expedited recommendation regarding this issue. What are your thoughts?
Absolutely for that. And actually, if you go to the large trials session tomorrow,
I know.
We'll be reporting the 10 Kraus trial results, and co-chair Professor Amot will be reporting those. So I will be there tomorrow, but we definitely need to see much more research across these interventions and the screening that goes before that process as well. And for anybody that's doing any of these guidelines in future, maybe take away from the number 13. It's not necessarily a lucky number to have that amount of PICOs included in a guideline.
Yeah, we're now doing with Professor Turk and other colleagues acute reperfusion guidelines. We have 15 PICOs, so I can feel you. I understand what you say.
Good.
So if there are no questions, let us move to the last presentation. It is my privilege and honor to call to the stand Professor Steiner from the University of Heidelberg, who is also chairman in the Department of Neurology in Frankfurt. He's going to present the latest ESO Guideline